Well, thank you to all our speakers. While you're thinking about we have about 25 minutes for question and comment. While you're getting your thoughts together, I'll kick off a question to Brent and Tom. I guess I've picked up kind of two different models for sustainability, both from this morning and from your commentary. And I wonder if you had any reaction to them. The first one is sort of what I would call kind of an acceptable cost, reasonable value as the value proposition, sort of the activities of a learning health system aren't too costly to me as a CEO or CFO of my system. They bring some value. Some of it's easy to measure and some of it's difficult to measure. Some of it relates to our mission or to our nonprofit status and everything. And as long as that all kind of works from a budgetary point of view and it doesn't break the budget, that's the model of sustainability. What I heard you two talk about was a different model of sustainability, and make sure I have it right, which is I heard you both say essentially that your continuous learning and improvement system should pay for itself, that it's sort of a contributor to the ROI, whether financial or non-financial, clinical or financial, to your systems. First, do I have that right? And if so, what are your comments about sort of the differences between those two approaches?
First thing, Lou, is you do have it right. We set a goal, our CFO did a few years ago, for something we call CPI +1. We want our rate increases on the population to be 1% above consumer price index inflation. I like to say that GDP -2, which means that you bent the cost curve and the total cost of healthcare to the nation actually drops. We had set a goal of hitting it in 2016. We came within a hair's breadth of making it last December. And we're probably past it now. It's about another $400 million per year out of our cost of operations. And each time we meet, we tally up what our clinical improvement has done for that. Last time it was, we got through the first 6 projects last year of about 20. They were the big ones, $39 million in cost savings. When I said make it your core business strategy, it's a compelling business strategy. Now, people have hinted at it. It doesn't work very well in a fee-for-service system. You're punished under a fee-for-service system. That's why Intermountain is shifting to capitation, basically as rapidly as we reasonably can. We think that that's where the future is. It ties into other work of the roundtable that Mike leads here. When we estimated 35% waste in the system, as I said at the time, I thought the real number was over 50% based on some other work. It's at $1 trillion per year, huge financial upside. It's about taking out the waste. There's a huge amount of waste, and if you can extract that waste, wow, what an opportunity.
Yeah, I don't have much to add to that other than we're not quite as far along in making the calculations because I think it's earlier programming, but our CEO looks at it as whatever we end up with as a payment mechanism, efficiency and effectiveness and quality are going to be part of that equation, and we plan to excel in those. So, to us, it's an investment in efficiency and quality simultaneously. I think we see it in the rest of our lives that there are much more efficient, effective ways of delivering packages and a variety of other things. Clearly, we already see a documentable financial benefit that's greater than our expenditure. So, yeah.
I'm Jeremy Boland, the Chief Medical Officer at Mount Sinai Health System in New York. And, at a number of forums, I've been very, very impressed with the handful of health systems that seem to have figured out this holy trinity of scholarship and improvement and fiscal responsibility, and not sort of chasing the grant dollars, but really building it into the ROI of the organization. And, whether it's Intermountain, Brent, or it's Virginia Mason or Geisinger or a few others, what always strikes me is that we hear it. I think we know it, that what you've done is what we all need to do, but none of us do it. And I guess what I'd like to ask you is, having been at this for a long time and having been in many forums where you've talked about what you do and what are the key points and what we all need to think about, what's holding us back in being able to make the kinds of transformations that you and a few other key organizations have been successful in making?
So this is pure belief, so don't trust it too much. This is in my experience. I build infrastructure. That's what I do. And if you build the right infrastructure, it makes it easy to do it right. I don't have to improve my colleagues' moral commitments. I don't have to improve their work ethic, their dedication to patients. It's there in spades. I need to build an infrastructure that makes it easier to accomplish our shared goals. For me, it takes two main forms. One is I run that ATP, which is sharing the concepts behind it broadly. I mean, it should have started in medicine. It makes such perfect sense from a medical model. But it's sharing that broadly so many can lead. And the second is data systems. I still think my biggest leverage comes out of the data systems. It was my extreme good fortune when I, by accident, dropped into Intermountain. They had that activity-based costing system, first in the world. But they can measure cost accurately at an individual patient level, at a granular level. And we've just expanded it over the years. And then just year over year, you just keep building out those data systems so things become transparent. Now, I object to the government at this level. I think their definition of transparency misleads us. For me, transparency means that when a clinician counsels with a patient and you're considering different treatment alternatives, that I have sufficient, not perfect, but sufficient information to accurately tell if I choose this course over this course over this course, what's most likely going to happen to me. So that as a patient counsels with a clinician, which is how it nearly always happens, you can make wise choices. At the same time, you're making it transparent to your clinicians that this is the consequences to this person I'm helping. So often they don't have that clear line of sight. And mostly what I've done is just given them a clear line of sight. I think that's what you do.
Thanks, Jim Rohack with Baylor Scott and White Central. So the question I actually have is for Dr. DeSalvo. So here's the story. We're very interested in data. Scott and White funded our own homegrown medical record 30 years ago, and then the meaningful use standards came out, and we couldn't meet those, so we went to a vendor who promised they would be able to handle our 2 million outpatient visits a year. After 75 million of sunk costs, we're now with another vendor, and none of the vendors want to talk to each other. And so now with our northern colleagues, there's a quality alliance. They have 46 medical records of the individual doctor's office that they're trying to manage because none of them talk to each other. So here's the story. Scott and White is where the Fort Hood shooting occurred 6 years ago, and then recently. The Department of Defense can't talk to the VA, and certainly none of them talk to the private sectors. So as you are trying to push all of this on the private sector, we've heard that the government has given up their hands and won't even fix the Department of Defense, not even talking to the VA. So please understand the cynicism in the world when you guys are coming out with all these rules and regulations and then you can't even implement it yourself. So what's the solution, and when will we see it, that will have all these electronic systems be able to talk to each other, both from the private sector and the public sector?
Like this? Yes. Well, actually, thank you for the question. It's a story that we hear a lot. It's a story that I experienced up until 3 months ago when I was practicing still in New Orleans. The success story is that now there is data that can be shared. Let's just start with that, because we have come a long way in developing a set of standards that we allow us to move after 30 years to looking more like what Brent's built. It took him some 30 years to get that far, so let's also reflect on that. The goal for us is that we first of all, let me just change the language. I don't want to push anything on the private sector. What the goal is to work with the private sector, whether that's providers or vendors or payers or consumers, to come to a resolution on how we will decrease the optionality, which is what you're describing, the technical optionality and all the ways that you can document that gender has 17 different types, and is it M and F and everything else, or 0 and 1 all the way to 16, right? So decreasing that optionality, while we're also thinking about how we open the architecture of the vendor products so that there's an opportunity for technology like APIs, these programmable indices, to help pull data out if you're going to switch vendors, to make it easier, to then drive some competition about the usability or the user interface of those, or to enhance the user interface. So I think you're seeing some signaling from us at ONC and from CMS, but ONC in particular, in our certification NPRM that's out now, where we're asking some questions about what that looks like to open architecture and kind of drive some innovation in a space that allows it to do the things that you're asking about. Importantly, it also enhances interoperability. But I'm going to now tell a sort of, and let me reassure you this, the VA DoD conversation is not a dead conversation. It is, the federal health architecture is the table at which we sit, where we make those decisions. We just resat the table under my tenure last week, or perhaps the week before, I'm not oriented, in the last few days, to say, let's define interoperability, let's make this work. And our team, Doug Fridsma, who really should be here today because he's been instrumental in PCORNet and other things, is driving the help on the DoD acquisition, which will make a lot of these things more real in the marketplace. But the VA and DoD and SSA and everyone else is very engaged and wants to make this work. And I'm intent on making it work. And when I get on intent on things, it's good, maybe, or not, depending on who you are. So, because I think that's important for the soldiers and the veterans. Let's just start there. But once we make some of those platform decisions about privacy and security and the standards and the governance of that, I think it gets a lot easier. I'm going to just finish with this, and I'll be quiet. Even today, you find doctors that carry around an index card in their pocket with their patient's information on it. And so we all found a way that we would take a giant medical record, even for our sickest patients at a place like Charity Hospital, whose charts were like this, and put it on an index card and carry it around in our pocket. We got down to a core set of information that mattered for the patient and that would allow us to transition care between shifts, et cetera. So I think where I'm going with this is, I think part of the excitement of the last 5 years was that we could, so we did. We found lots of ways to define and imagine. But where we have to get now is really focused and serious and parsimonious about what it is that matters, what are the measures that matter, what are the core pieces of information that matter for the clinical environment that we need to share. And that begins to simplify the conversation about interoperability and everything else. We don't need to share, these guys don't need to share everything, but they need to share some core. So I hear you. I think that it's a common story. It's something that we're hell-bent on solving. Can I say that? And that technologically there are ways to do it now that probably didn't even exist 5 years ago.
Steve Laws with Nemours. A question maybe for all of you, and a person from HCA. If 70 to 80% of costs in a system are fixed cost, is there room, or why isn't there more research going on financially with the clinical integration to lower the fixed cost? That's the part of the cost that really is going to be more dependent upon volume and system volume, rather than the variable cost which you talked about. What are you guys doing primarily to work on that aspect?
The reason I referred to variable costs is those are the most easily calculated for those specific interventions that we're currently undertaking. I think that there are, opportunities and when you purchase hospitals in a given geography, there is an opportunity to begin to condense the program so that you have less need for very expensive equipment and so forth. I mean, we certainly pay a lot of attention to that, and we have pulled almost everything out of our hospitals that isn't related to patient care. So billing is done regionally, computers are run centrally. I mean, so many of those things. I think that the biggest challenge is in kind of the technical arms race. Robotics might be an example, things like that, where you feel you have to have them to be competitive in a given market, to get the most advanced surgeons, to and what patients are demanding. It gets back to the conversation we heard about this morning about, maybe we're better off. How do we have the conversation with patients that maybe robotics aren't the best thing or that well researched, even when patients are coming in demanding it. So when you're
We track this fairly heavily too. Over half of our savings are fixed cost savings. So for example, when we ran appropriate elective inductions back in 2001, we took, I think, 45,000 minutes out of labor and delivery. And we could deliver about 1,500 more kids each year without a single additional labor and delivery suite or nurse to go with it. This is one area where it's really helpful to be a system, because you have to manage out the fixed resource, you have to match to need. And as a system, it's easier to do, frankly, and also our communities are growing a bit. I've been making a prediction that we're going to see a surge in demand associated with baby boomers hitting their chronic disease years, primarily advances in technology, other shifts in our population. And I believe, with no evidence again, no careful analysis, I do have some evidence, just no careful analysis, that one of the ways that we'll meet that demand is not by training more physicians or adding more hospital beds, but by becoming far more efficient. So we have the potential to fill those fixed cost savings with additional demand moving ahead. It's a balancing act to some degree. But you're absolutely right. You better be able to manage fixed costs in this area.
Oh, yeah, go ahead.
I think I'd like to just respond in terms of a patient contribution to this, because I think that sometimes isn't seen as being an opportunity. I think the idea of patients demanding something, some of that's historically based. If they think that this is something they should be able to get, then they're going to be asking for that, partly because they may not have enough of the information they need in order to really understand whether that's going to be a beneficial intervention for them or not. So I get back to this notion of give me some sense of what the data is in relationship to the data I'm going to share with you, so we can share together how this outcome might look. But I also think that it's time to start thinking about patients as from an assets-based perspective. What are the assets that patients and others can bring to the table that actually, once you consider that and put that into your equations, they can contribute to your success by helping you be more efficient, by better understanding how they can contribute to that. But I think we marginalize their contribution too often, and I think it's time to stop doing that, because I think when we bring them to the table, they're going to be more accountable for the outcomes ultimately. So.
Hi, I'm Brie Patrick. I'm the patient rep on the PCORNet Coordinating Center Executive Leadership Committee. I had two questions for Dr. James. First of all, when you were discussing the proposed research that might be rejected at Intermountain if it didn't align with the priorities, I was wondering how patients and caregivers are aligned in setting those priorities and how you're engaging them in that process. And then my second question is, how are you balancing the timing of implementation of your research findings with peer review publication?
Relative to your first question, I have those, what we call clinical development teams, are fairly extensive. We fund them. Many of them involve patients directly, but that's where the research agenda is set. It's always in the context. So on the IOM Committee on Quality of Healthcare in America, where we published Errors Human and then Crossing the Quality Chasm, it was Don Berwick who came up with the idea of patient-centered care. But the way we actually defined that at the time, patient-centered care meant that you designed the care around the way the patient experienced care. In quality improvement language, I'd call that processes. Patients experience care along a process of care. So you don't design around the facility. You don't design around the superstar physician. You don't design around the technology. You design around the process. In the old days, we called it continuum of care. You see that idea? So what we did internally is we built our care delivery system that way, designed around processes. What are the clinical conditions, the way the patient experienced the care, and then you design around it. I think that's more than half of patient-centered care personally. And then you involve patients to get their experience of how it works for them in a consistent way. But for me, it's all of those clinical development teams. That's what they do. So it's really different for us. Most of our goal setting happens top down, except in clinical areas where it's completely bottom up. The people off the front line who are living this every day. And it's fairly dramatic when you actually live it and take a look at it that way. The second question relative to publication, we're really crappy at it. I would guess that we're publishing 1 in 20 of what we ought to. And the reason is we don't value it very highly. As an organization, as soon as you get the answer, it's on to the next question. There's a line standing outside your door with really fun questions. And occasionally you take the extra 10, 20% of time it takes to turn it into a research publication. But the fact is we don't do a very good job of it.
Robin Wittenstein from Penn State Hershey. It seems to me as I listen to this and we think about the contributing factors that have gotten patients into our offices and into our institutions, there are so many things that happen that have nothing to do with the medical care that we're providing to them. And it seems in particular, Sally, that engaging the patients to help bring the others to the table who have to be part of the solution, not just for our hospitals. And I think as providers of care, we have to be better at what we do, but really to help prevent the patients from getting to us at the point in time when they do. And I'm not sure if we can use the patients to help engage the school systems and others that really are critical parts of health rather than just medical status. And I'm not sure if we've thought about how to use PCORI as a way to help bring in other kinds of institutions that really could have a tremendous impact long-term on her health status.
I'll respond to that, and certainly defer to others on that. But I do think that there is a significant need for us to do a sort of, as I sort of mentioned, an assets-based inventory. You know, as people, understanding what are the communities that make up our lives and actually keep us going on any given day, and then how do we assess our health? I think Karen's question of, you know, how would you rate your health is an important question. I would suggest that most people, patients aside, most people sort of think of their health as something that just operates in the background. And then when it fails for some reason, we tend to be surprised. So I think we have to do a much better job, and that needs to begin in the education system. It needs to begin at much younger ages to help people understand that health has a value. And when it's compromised, you're vulnerable. And when you're vulnerable, you then are subject to things that maybe you don't want to have as outcomes. So I really believe strongly in this sort of this community perspective. What are the communities that are circling around our lives, and understand what the context of those are, and then bring that to bear on not only helping people, but then patients as well, help us better understand their experiences. Because the continuum of care, as most people measure it, does not include the experience of self-care and care for the most part at home. So.
Let me just contribute that one of the most exciting challenges about creating interoperability is to just break away from the notion that it's about vendor-to-vendor EHR conversations, but it's really about creating a flexible enough platform that other data can come in, whether that's from social services agencies, from schools, from consumers, from caregivers, remote sensing. And that is, I think, the necessary challenge if we want to get to the third part, if you want to think of it that way, of the three-part aim of improving health, because that's the other 80% of the equation.
Thank you. Hi, this is Emmy DeLand from New York Presbyterian Hospital, New York City. I'd love to hear from any of you a little bit about if your hospital provides translations in 101 languages, and the ethnicity and diversity of the population is inner urban. I'd love anybody to comment on what you've done to engage patients in that kind of an environment.
I'm just going to go back to you and say you probably have some ideas more so than maybe some of us on the panel, but I would actually say that you know, we have not been around that long in patients like me, but one of the things that we have done is created what we call our user voice dashboard. Our site is predominantly English speaking, but we allow any language to come into the site. And when it does come in any other language, we translate that using particular tools. We validate that back with the patient, and then it becomes part of our synonymy. So ultimately, that if someone else with that same language, we're putting that information in, although it would have been showing on the site as in English, there would be a translation of that same term in our synonymies. So that's one way we've approached it, but I'll let the others speak on the hospital side.
All I could say is, and you know, it depends on the location. Obviously, we have to look at which languages patients are speaking who we're treating. When I was in Los Angeles, we, I think, had 23 different languages we provided on-site translation for within a reasonable period of time. We did it electronically if it was more acute, but there were obviously a few predominant ones.
Yeah, we have local services for common languages And I know that we're using some sort of a third-party service that works electronically through some sort of a video link that gets us out to a much wider range of medical translation. And then just you analyze your local population. So Spanish we have to have ready to go locally. Many of our care providers speak pretty good medical Spanish these days, for example. But then you just build out from there. And there are some pretty good services where you can buy those now. And they come in through a video link and translate for you.
I think the much harder question is, beyond just translating the words, is having an appreciation of the cultural differences. And, we worked with someone in LA, I know, to build out, a sort of a pamphlet of the most common other belief systems around health that we could have, sort of on site for individual practitioners. I left before I found out how well it's deployed, but I have to, I appreciate, the challenge.
Brent, I was struck by your comment about rejection of research opportunities because my guess is there's a filter and something doesn't matter. So why does research that comes down the pike to your place not matter? And what are you really saying directly? Why do the teams reject it? Is it because it distracts you people from sort of the sense of urgency and performance? Can you say a little bit more about it? Because that's a pretty striking statement, and I don't know that all of us do it that way. So.
My research agenda is set by those clinical development teams who are directly involved in the care delivery around a particular process. And the question is where do we best improve patient outcomes in terms of clinical and cost outcomes? That's the way the question gets asked. I'll tell you honestly, much of the funding, tens of millions of dollars of it, comes from industry, big pharma, far more, of course, than from other sources, device manufacturers. The trouble is my teams have limited attention span. And I can't get them distracted. And a kinder way of saying it is I know for those things to work, I have to have an internal champion. And there's just a limited number of internal champions. Where do you want them to focus? How do you want them to set that agenda? Do you want to have them base it on external research funding? You want somebody to be able to buy that attention? Or do you as an organization have a pretty clear idea of what would best serve your patients?
I support what you're thinking. I'm wondering what that says about research priority setting.
I think it says something about academic medical centers.
Don't say that.
Maybe we should move on to the next question.
Lou, can I just make a follow-up comment on that? One of the things I want to be sure that people in this room hear, patients will be intolerant. If you're conducting lots and lots of research and it isn't going anywhere, they're going to want to see some outcomes that are actually going to benefit them. And I think one of the concerns is if you're waiting on something you know works until you're going to publish it, that's not going to be tolerated by patients. If you think that your hypertension study was a failure because it couldn't get funded in your institution, that's not the way to look at it. Let's start to look at different ways of being able to make something that actually did work sustainable in your environment. So if there's something patients can do to help support that, then please, we would certainly be interested in working with you on things like that. But I really want this room to hear that if you're going to do this work and we're going to be asking patients to participate, you need to give them back something, and you need to give them back something quickly.
I need to say what I just said a little differently. This is to make it a little sharper, actually. Any organization that doesn't put their patient outcomes first should not be allowed to treat patients. If your research comes before your patient outcomes, you should not be allowed to treat patients.
That's well phrased.
That's a short version of what I just said. All right? And what I was describing was a method by which you put your patient outcomes first, given the fact that any organization has a limited bandwidth. As anybody who's led an organization comes to profoundly appreciate. So I've got to get them focused on the things that matter most first, right? And not get distracted from it. We set goals around that. We align resources around it. But patients come first. They come before my research.
I obviously adore your work, so this is not a personal conversation. I think the challenge, in advancing science at the same time as you make lives better and apply it, is building that bridge in the right way and is always asking us to think about that balance. And so I was just struck by your comment and thinking about, you know, in pediatric health, there's a lot of new discoveries that we need to make, including working outside the health system to make kids healthy.
Yeah.
They're not all going to come just from making the better wheelchair, as we say in Cincinnati. Sabin did make a difference to kids in polio. Last year, polio was eliminated. So how we do this in the right tension, and we will always continue to feel that tension. So I'm just struck by your comment and the opportunity that a system like yours that has such reliable processes could contribute to new scientific knowledge of a different kind.
Well, I think this was a great set of comments, the presentations, and the Q&A. So please join me in thanking the panel, and we'll take a break.
I just want to remind us that this was a session on sustainability, and I actually think that last question and the dialogue that occurred was something we should remember. You know, patients come first, and if we're going to partner with patients, there has to be some give back, and that's a lot of what sustainability is going to end up be determined by, not just whether it's a great business deal for our systems, but what we do to help patients. So with that, let's take a break. We're going to get back here at 2:45. I want to thank all of you for being on time. We're right on time, and the panelists too. Thanks.